respected chairpersons, teachers, and friends. My topic today, and at the outset, let me thank the organizers for having given me this opportunity. My topic today is early diagnosis of bacterial and fungal infections and cirrhosis. Why early diagnosis? Maybe this slide would explain why. This is a global study on the incidence of MDR as well as XDR organisms worldwide. And even though we didn't get any gold in Olympics, we stand first with MDR percentage of 72 and XDR percentage of 32% in the prevalence of these organisms in patients with cirrhosis admitted with infections. So what is the importance of this? Cirrhosis basically is prone to bacterial infections, and there is increased risk of organ failures and mortality. And if you have an MDR organism that is infecting you, there is a very high risk of organ failures and mortality. Why is, about MDRs, you have the methicillin-resistant Staphylococcus aureus, the vancomycin-resistant enterococci among the gram-positive organisms, and among the gram-negative bacilli, you have the ESBL-producing Enterobacteriaceae, the carbapenemase-producing Enterobacteriaceae, and the carbapenem-resistant non-fermentative Enterobacteriaceae, which includes Pseudomonas and Acinetobacter baumannii. Sepsis and cirrhosis is quite common. This is multifactorial. Basically, the cause is portal hypertension. There is increased translocation of organisms producing PAMs and the other dams which act through TLRs to produce cytokines. There is a heightened inflammatory state, a systemic inflammatory state, which finally leads to immune depression and immune palsy. And along with that, there is reticuloendothelial cell dysfunction, reduced opsonins, and complement levels. You should understand there are certain risk factors for MDRs, because these patients, if you have these risk factors, you should always suspect MDR infection. These are nosocomial infections, recent hospitalization, recent systemic antibiotics, recent invasive procedures, recent infection or colonization by MDRs. And long-term norfloxacin prophylaxis is getting a bad term, especially for primary prophylaxis, because more and more papers are coming that it could be deleterious. ACLF and diabetes mellitus are also potential risk factors for MDR organisms. So you should have a very high suspicion of MDR organisms if you have these risk factors. It is present in about 32 to 40% of patients with decompensated cirrhosis. Maybe 40 to 45% could be community acquired, and the rest could be hospital acquired, healthcare associated, and nosocomial. Now, how do you diagnose infection and sepsis? If you have a patient with cirrhosis admitted to you with increasing ascites, presence of AKI, presence of HE, which is increasing, actually that is your slide. That is from your paper itself. So you assess the temperature, you do the SOFA score. SOFA score has been done in patients not with cirrhosis but in the ICU, so it may not be ideal for patients with cirrhosis. Use QSOFA, which includes three things, that is altered mentation, a respiratory rate more than 22, and a systolic BP less than 100, and presence of fever, which could be indicative of infection. And you look for the localizing signs, as in abdominal tenderness, diarrhea. For UTI, you look for dysuria, and do a urine examination and culture. Cough, sputum expectoration, and dyspnea could indicate pneumonia. The skin and soft tissue have its own presentations, and C. diff can present with diarrhea. Then you go for the investigation. Basic investigations are W cell count, which is mandatory in all the patients. Then you go for a chest X-ray, urine examination, cultures of the blood, urine, ascitic fluid, and whichever part of the organ you think it is affected. And once you've done that, you can go for the blood markers, blood biomarkers like procalcitonin, CRP, NLR, and HDL. We'll come to that later. You have got the diagnosis of infection or probable sepsis and go for antibiotics. So if a patient is admitted without these symptoms and signs, then he develops those inside the hospital, then there is a high chance of nosocomial infection with MDRO, and you should always suspect that. The biomarkers, WBC counts, NLR, MLR, procalcitonin, C-reactive protein. We'll come to that later. So NLR is an easy thing to do. If it is more than 8.3, usually the patient is having infection, and an NLR more than 30 usually indicates an 80% mortality. PCTA, we will come to that in detail later. CRP and IL-6 may not be ideal in patients with cirrhosis because the liver is either the site of destruction or formation of these biomarkers. And HDL-C is an interesting thing. If you have an HDL less than 30, it could indicate infection, and if it is less than 17, it could predict mortality. But one caveat is that HDL is often reduced in patients with cirrhosis and especially DCLD. Procalcitonin level should alone not be used to diagnose sepsis, but one utility would be if you have a baseline level and if the level comes to less than 0.5, or if there is an 80% drop in the procalcitonin levels, then that could be, along with clinical judgment, you could make a decision regarding step down of antibiotics. It is falsely increased in non-infectious condition of which cirrhosis, especially decompensated cirrhosis, is a part. So what to do with procalcitonin level in patients with cirrhosis? One way to go would be to look at the bilirubin as a marker for severity of the liver disease. One study has shown that if you have a procalcitonin level of 0.38 in a patient with less than 5 milligrams of bilirubin, it would be comparable to a level of 0.92 in a patient with a level of more than 20 milligram of bilirubin as predicting infection. Now there are other biomarkers, presepsin and resistin, not widely available, is as good or as bad as procalcitonin and CRP. And there is a soluble TREM1, the SCD163 and MR-ProADM, which is the precursor peptide of adrenomyelin. All these can predict mortality in sepsis. These are not widely available. So we rely a lot on culture and sensitivity, but the problem is time. It takes about 2 to 5 days for the culture to become positive, so you have to give them empiric antibiotics. So prompt de-escalation to targeted anti-infective agents is compromised, and antibiotic stewardship goes for a toss if you wait for culture and sensitivity. So the need of the hour is rapid diagnosis. How can we do that? There are so many molecular techniques that are now available. The MALDI of MS is one, and FISH, both of which are useful in identifying the organism. But you cannot do any sensitivity or resistance pattern, but you can identify the organism. In many a case, that identification itself could be enough, especially for Candida. And if you want to look at the sensitivity and resistance patterns, you have got the ANAT by real-time PCR, much more expensive. For example, you have got the expert MRSA for diagnosing MRSA, and the BioFair film array, which is also available in certain centers, which gives you the resistance pattern of 8 gram positive and 11 gram negative organisms, as well as the 5 Candida species. If you have this, you should use this, especially if you are suspecting patients with MDRs or if you are suspecting a fungal infection. So again, it's the same. It could be culture-based, it could be non-culture-based. And look at the right side for the time. MALDI takes less than 1 hour to identify the organism, and most of this, the result is obtained within 4 hours, which is perfect for targeted therapy. So nowadays, what you have is the left extreme, classical cultures taking 2 to 5 days. Patients are on empiric antibiotics, which are not good as far as development of MDRs and XDRs are concerned. And we are moving more towards the right columns, where we have culture-based and non-culture-based molecular techniques, like the quick fish and the MALDI. You identify the organism, go to the lateral flow assay, and you got targeted anti-infective therapy, which is the goal which we are trying to achieve. Again, we have the non-culture based, the Cepheid Gene Expert and the Curatis Univero. Again, you do it within 4 to 6 hours, so that the patient is on the correct antibiotic and infection is better controlled. Now, shortly about fungal infections. Candida species occupies the prime position. About 2 to 8% of patients with infections admitted, with cirrhosis admitted infections are suffering from Candida. Albicans still remain the commonest cause. That is good in a way because they are still sensitive to triazoles. But the non-albicans are taking over. Nowadays, 8 to 41% of patients infected with Candida are with the non-albican species like Glabrata, Cruzi, Tropicalis, and Parapsilos. Aspergillus comes first, and then there are a few cases of Cryptococcus, Pneumocystis jirovecii, and endemic mycosis. Overall, 7 to 10% of admissions of DCLD, 10 to 4% in critically ill patients, and 40% in post-transplant patients could be due to fungal infections. Again, immune dysfunction plays a major role in invasive fungal infections, especially dysbiosis, which is quite important because you give a lot of antibiotics, you have got the portal hypertension, candidal overgrowth is there is increased translocation, you get an invasive fungal infection. Again, risk factors you should keep in mind: abdominal surgery, diabetes mellitus, prolonged surgery, recurrent transplantations, repeated transplantation, recent broad spectrum antibiotics, central venous catheters, renal replacement therapy, prolonged stay in the ICU. And you find that ACLF is a major risk factor for most of the infections, either be it bacterial or fungal. For invasive candidiasis, identification of Candida species using culture-based methods remains gold standard, but the sensitivity is only about 21 to 75%, which is not quite acceptable. The median turnaround for blood and tissue cultures is about 2 to 3 days. Species identification by the Vitek, which is much more widely available, takes another 24 to 36 days, whereas it takes only 30 to 60 minutes with MALDI-TOF and BioFire film array. And nowadays it has developed to such an extent, even without culture, you can directly go for identification using these techniques. The importance is that the rapid identification of Candida albicans reduces the use of echinocandins, which are quite costly for our population. And most of the Candida, at least Candida albicans, are sensitive to cortisols. And if you can do the 1,3-beta-D-glucan, this has got a very high negative predictive value. You may be able to de-escalate the treatment if the glucan levels are negative. For Cryptococcus, it can either involve the lung, it can be a cryptococcemia or a cryptococcal meningitis. And as we used to do previously, direct visualization using Indian staining is an inexpensive technique, but has got a low sensitivity of less than 85%, but should be good enough in most of the patients. The point of care lateral flow assay is less labor intensive and is more sensitive and specific, about 95% sensitivity and specific, and is the most commonly used, though it is a bit expensive. Aspergillosis, there are radiological signs, and the IDS, that is the Infectious Disease Society of America, has suggested bronchoscopy is a bronchoscopy with BAL, and Aspergillus galactomannan estimation has a sensitivity of 84 to 86% and specificity of 89%. In blood, it correlates with invasive growth, but has low sensitivity in liver disease. Pneumocystis jirovecii, again BAL with immunofluorescent staining and NAT, sensitivity and specificity of about 90 to 95%, which is quite good. Again, 1,3-beta-D-glucan has a very good negative predictive value. So if it is negative, it means that either your infection has been controlled or you are not having the infection. Coming to dimorphic fungi, histoplasmosis, blastomycosis, and coccidioidomycosis. Definite diagnosis is by visualization of the fungus. It takes a long time to culture of more than 2 weeks, so detection of either fungal antigens and or antibodies is useful, and BAL with histoplasma antigen by EIA is probably the best method. So in conclusion, the problem of MDROs and XDROs is a grave one. Cirrhosis, especially decompensation, is a high risk for sepsis. Early diagnosis and targeted anti-infectives are the need of the hour. Knowledge of risk factors helps in increasing suspicion of MDROs and fungal infection, because if you don't suspect that the patient could be having that, the case is already lost. Rapid diagnostic tests for identify the organisms and for antibiotic sensitivity should be used. It is absolutely essential to know the antibiogram. Different hospitals will be having different antibiograms, and if you don't have the antibiogram of your center, it is a waste. You'll be experimenting with multiple antibiotics. An ID specialist and microbiologist should be in the loop. Microbiologists especially to pick up the cultures and to do the tests, And studies have shown that if the ID specialist is in the loop early, it actually decreases mortality. And antibiotic stewardship should be strictly followed. Thank you.